really interested as a training center in the future public health needs and developing the workforce of students who are in our programs, but also in the current workforce and how we assure that the current workforce is ready to go for the future. So our session overview for today was really about how do we create a 21st century public health infrastructure? How do we create that with the tools we have now and the vision for what we think our needs are in the future? And so we asked Dr. DeSalvo to help us better understand Public Health 3.0. And our next two presenters are going to discuss their state's approaches about Public Health 3.0. And after their very brief presentations, we are going to have an open panel where we have a few questions that are prepared but are going to be turning to you to ask you for some of your questions. So that's the goal. Then when we'll break for lunch, we'll come back and we'll get even more granular about what exactly are we going to do with the workforce of today to help develop and meet the needs of our workforce. So that's the roadmap of where we're headed. And with that, I am pleased to introduce our next speaker. So we have Nebraska and Kansas represented on the dais right now. First up will be Susan Bockrath, who is the Executive Director of the Nebraska Association for Local Health Departments. I'm not going to read her whole bio, but I will tell you that she has done public health work in Nebraska, Georgia, Minnesota, Missouri, and Rhode Island. Like, there's an interesting outlier there, which is actually where I was born. So, yay! Thanks for Rhode Island. Rhode Island, and her real passion is around health literacy, which has a significant influence on all of this work. And as the executive director of the Nebraska Association for Local Health Departments, she has worked with the board to oversee tenfold growth in the association's scope of work and budget. And so congratulations on that. That's pretty cool. Susan has Susan has a master's degree in public health from Emory University's Rollins School of Public Health and is also a certified public health education specialist. We don't have nearly enough of those in my state, so I wanted to make sure I mentioned that. And so welcome, Susan.
I want to just talk a little bit about our public health system and actually our organic process of kind of arriving at working toward Public Health 3.0. And I call it built late, but for the future. Is this working? There we go. Because in 2001, the counties here that are colored in are the counties that had local public health departments, and the rest of the counties in Nebraska did not have a local public health department. And so as late as 2001, with the tobacco settlement dollars, and there are people here who were part of closer to that, thank you, David, we developed a public health system that is a regional system. We are covered by 20 districts. Our local health departments are all independently governed. They are not, so our health department is not sort of state-centric. None of our health department employees are state employees. But as of 2001, we became fully covered, regionalized system. And when we talk about Public Health 3.0 and kind of the structure of Public Health 3.0, we are not having some of the difficult discussions in our state about how do we consolidate, because we already started out consolidating. And frankly, that paves the way for some easier discussions about other topics. Related to the recommendations that Dr. DeSalvo was just talking about, we are also lucky enough that when we started late in this process, we started as chief health strategists. We didn't have that language to describe what we were doing, but our local health departments basically stepped into a space that already existed. In many communities, the safety net healthcare providers were already in place, or some of that work was already in place. And so from the very start, our health departments were working on community health needs assessments, community health improvement planning with partners from across those districts, and some of those districts are larger than the state of Connecticut. So these are vast areas. They were working with those partners to really think about what are the gaps in the services that are here, what's not already being done, what can health departments do to assure that those services are done. So they did not want to come in and try to compete with other providers or other partners that might be able to provide those services, but when there were gaps in those services, they wanted to look for opportunities to fill them. And sometimes that was partnerships, sometimes that was doing it themselves. We also applied for the CMS Accountable Health Communities Grant and also were unsuccessful. However, as part of that thinking, we developed this model as a way of sort of describing some of the capacities that our rural health departments had to start being that bridge between providers of health-related social needs, which was the language of that particular opportunity, and our partners in the provider world. But as far as what our health departments are doing now, our health departments are very involved. Several of them are involved in providing oral health prevention services. We have some outstanding home visitation programs, Healthy Families America, some national standouts in that. We're doing a lot of worksite wellness work. All of these are within, as part of coalitions, collaborations, collective impact groups that are organized across our state. And then diabetes prevention program is another standout area. And then when we look at sort of a specific example of where we're working with across sectors with non-traditional partners, we have done a lot of work with veteran and military communities across rural Nebraska. And that has really benefited our health departments in a number of ways. It's benefited our veterans and military members and their families, but it also has been a pathway into having conversations with folks who weren't necessarily allied with local health departments. And so that's work that we're very proud of. Related to FAB accreditation, this is something that our health departments are taking very seriously. We have 2 accredited health departments. Our state is accredited. Our state health department is accredited, but we have 2 health departments that are accredited. We have 2 more that have had their site visits, 1 other that's having a site visit on Friday. So as far as the impact of accreditation in our state, it's pretty high. I would say that almost all of our health departments have identified that they are on the path to accreditation. They're at obviously different phases of that, but that is something that our health departments have been willing to embrace. When we talk about, I'm going to skip over the data thing because the data thing is, we struggle with that. And rural communities, I think, have a particular challenge with that because of their just the complexity and the lack of, it's harder to sort of develop those coalitions around data in rural communities and develop those resources. Our health departments, like I said, were funded initially by funding from our tobacco settlement. That across all of our health departments adds up to about 1/3 of their funding at this point. Many of our health departments get no local funding. And so we are in a position where health departments have about 2/3 of their funding that they can't rely on. So as a quick example, and then I'll stop talking. This is an example of one of our smaller by staff health departments that serves 4 counties in northeastern Nebraska. 46% of their funding is what we call vulnerable. So that's funding that comes from contracts or competitive grants that they cannot necessarily rely on. And you look at their staff, they've got 9 warm bodies, but only parts of those bodies. And so, the dark colors, the dark green and the dark blue, are basically the funding that they can rely on and how that's distributed across the people in that health department. That health department also had an outbreak of avian flu, 3 tornadoes in 8 months, and a major tuberculosis outbreak. And so when we look at the people who were serving those folks during those, who were sort of deployed in those emergencies, we see that over half of them were not sustainably funded. So sustainable funding is really where we, and I know that this is nothing new to you, but this is an area where we are really struggling. So we really think that 3.0 is kind of where we want to go. We're moving in that direction, and we're happy to be part of this conversation to sort of learn more about how other states are doing it. I know Kansas has been much more organized about it, while we've just sort of morphed into it. So thank you.